and then we're going to let Dr. Shafeena take it away.
Okay, so I'm going to just share my screen here. Can you all see this in full picture? Yes? Okay. So my name is Dr. Premji. I am a family physician here in Calgary, and I've been practicing for 12 years now. And after I completed my residency in family medicine, I then pursued a one-year fellowship in women's health. And I practiced full scope family practice for women only up until January of this year. I also provide low risk maternity care at South Health Campus and have been providing menopause care for women since 2015, before it even became a hot and sexy topic. I love caring for women because I think women's health has always been under researched, understudied, underrepresented, and women generally, my experience has been often are left feeling very vulnerable through every stage in life, whether that's puberty, contraception, pregnancy, postpartum, and menopause. And so why I love this area is because it gives me the opportunity to really empower women and give them the validation of many of their symptoms, but also to be able to offer them treatments and therapies and options for caring for any of their medical symptoms or conditions. So this is a little bit more about who I am. So you can see behind my name, I have a few letters, but the ones that I want you to remember and be aware of is the last four, which is a Menopause Society certified practitioner. And what that means is that in 2015, I wrote an exam from the North American Menopause Society, which is now called the Menopause Society, which essentially gave me credentials to become an evidence-based menopause provider. Menopause care has been completely eliminated from the residency and medical school curriculums for the last 20 years. And so if you have a doctor who has graduated in the last 20 years, they know nothing about menopause. Everything that I teach you today is all based on my own efforts to learn, me attending conferences, me going and reading online articles and really getting some mentorship through a few small number of experts across the country. And you can see in this photograph on the bottom, this is the Canadian Menopause Society Board of Directors, of which I'm very grateful to be one of the board directors since 2020. From this team, there are only 3 family doctors. I'm one of them. The rest are all OBGYNs. And so clearly family doctors who are the individuals who should be providing primary care menopause care to women are not being represented because, as I mentioned, we have no education. These are the top experts across the country. They are my golden colleagues who I absolutely adore, and they're the ones who have mentored me into becoming the menopause expert that I am today. So in Calgary, I own 3 medical clinics: the Village Medical, Mahogany Medical Clinic, and Milestone Menopause Center of Southern Alberta. All my clinics are in Mahogany. I see patients for referrals for pregnancy care, contraception, and menopause. I also work at South Health Maternity and Wellness, which is the maternity clinic. As I mentioned, I am a board director of the Menopause Society, as well as a medical advisory board member for the Menopause Foundation of Canada. I'm also a proud mom to my 2 little boys there, and my husband is my best friend, and he is also our clinic manager and keeps my life completely in order. So I would not thrive without him. I want to give you some menopause 101 and some history. So I don't know if any of you are aware of this, but I'm going to go back to 2002 because there was a large study that began in the 1990s. This large study was essentially looking at whether or not hormone therapy was beneficial in reducing chronic medical conditions. So in the 1990s, oral Premarin, which is oral estrogen, was the #1 prescribed prescription in USA. There was like over 3 billion prescriptions for Premarin. And so we thought, maybe hormone therapy is the elixir for youth and it's going to keep women young and it's going to prevent bad things from happening. And so there's a large study, and the largest study of hormone therapy on women, which began in the 1990s. And this study looked at over 18,000 women between the ages of 50 and 79. These women came from all kinds of backgrounds and underlying risk factors. So there were healthy women, there were smokers, there were women who had had a heart attack, there were women who had high cholesterol, diabetes, everything. And they thought, okay, let's have 2 two separate arms, one arm of women on hormone therapy, one arm of women on placebo. And let's see what happens in terms of stroke, heart attack, and breast cancer risk. In July of 2002, a huge outpour of media came through, which said that this study was prematurely stopped because women were developing stroke, blood clots, heart attacks, and breast cancer. And of course, the whole world erupted and thought that, okay, hormone therapy, if we thought it was actually going to help, has actually caused a lot of harm to women. And so doctors stopped prescribing hormone therapy. This is dangerous. This is not safe. So the prescriptions dropped significantly. Doctors stopped prescribing, and hormone therapy basically became non-existent. And this is why there's been so much fear around hormone therapy since 2002, which is now 22 years ago. So what this has led to is that the last 20 years, women have not been receiving the care that they need. But the problem with the study is something that a lot of people do not recognize. They lumped all of these women between 50 and 79, which is a 30-year difference, into one group. And so, of course, the women were all having all of these events. But what they didn't realize is that later on, this data was re-examined and looked at, and they broke it down based on decade of age. So the 50-year-old women, the 60-year-old women, and the 70-year-old women. And what they found when the data was reassessed is that the women in their 50s actually had fewer strokes, fewer heart attacks, and there was no change in breast cancer risk primarily. It was the 60 and 70-year-old women who were having more of these events. So what we now understand is that hormone therapy has a window of opportunity. And that window of opportunity is for women under 60 and within 10 years of their final period. And so this is why it's taken us 20 years to help break down all of these inappropriate public flashes of concerns around hormone therapy. Now, there's so many different forms of hormone therapy. And what happened during that time is that the women who were taken off their hormones, who still wanted to get hormone therapy, started making it compounded. And compounded hormones or compounded prescriptions are ones where a pharmacy can make it and they can manipulate the dosages and create it in such a way that it can look like it's appropriate or safer. And if you recall, about 2 years ago, in Calgary, there was a huge shortage of Ozempic. There was also a huge shortage of Advil and Tylenol for babies. And so what was happening is that they were getting compounded Ozempic, compounded Advil and Tylenol, but these products were also unstable. We actually didn't know where they were getting the sources from, and we weren't really confident in that prescribing them if it was actually providing the same effect and safety as the branded products. And this is the same challenge with hormone therapy, where we have prescriptions which are Health Canada approved, and then we have the compounded products, which again have come through because there was no other way of accessing hormones back then. And now this has become proliferated when we know that there are concerns around that form of hormone therapy, which I will address later on. So what is menopause? Menopause is a retrospective diagnosis, meaning you can only make it once you've gone an entire 12 months without a period. The average age globally is 51 to 52, but this can range anywhere from 45 to 55. If you have an IUD, if you've had an endometrial ablation, or if you've had a hysterectomy where your uterus has been removed, but your ovaries are still in place, you may not get a period. And therefore, it's really difficult for you to determine if you've gone into menopause. And so in that circumstance, you cannot use your periods as a way to diagnose yourself. And if you are on any form of hormone therapy or birth control pill, you can also not make that diagnosis. Menopause happens because we're born with a certain number of eggs. We have the highest number of eggs in our ovaries as a fetus. When we are born, we have about 600,000 eggs in our ovaries. When we hit puberty, we have about 300,000. And by the time we hit menopause, we only have about 1,000 eggs in our ovaries. Now, these eggs are no longer capable of ovulating, and we actually only ovulate 300 to 400 times in a lifetime. So all those other eggs actually just are lost through natural attrition. So this is why women go through menopause. It's generally a loss of ovarian function because there's no longer any more eggs to ovulate. Perimenopause is the time that leads up to that final menstrual period. And for women, this can last anywhere from 4 to 7 years, which means that if you are going into menopause at 48, your symptoms very well may start into your late 30s or early 40s. This is a time of chaos and havoc for the majority of women, where not only are there a change in menstrual cycles, but women also experience many physical and psychosocial symptoms in terms of sleep, mental health, energy, fatigue, brain fog, amongst many other symptoms. So what is postmenopause? Postmenopause is from the day of your final period until your last breath, which for women today can be up to 20, 30, or even 40 years. And so there's this idea that I just need to get through menopause, and that is incorrect, because you're not just getting through menopause, you are now living in menopause for the rest of your life. And as a healthcare provider who provides menopause care, my job is to help you thrive and stay healthy during your perimenopause, as well as for the rest of your life in postmenopause. There's also something you need to know, and that is when women go into menopause early. So there's two definitions you need to be aware of. Premature menopause under age 40, 1 in 100 women, so 1% of women, and early menopause between age 40 and 45, 5% of women. Now, this can happen spontaneously, where we have no explanation. The most common cause can be from a family history of early menopause. My mom went into menopause at 43, so she was a woman in early menopause. It can happen because you've had your ovaries removed, either because there was something on your ovaries, or maybe you have a BRCA2 or 1 mutation, where you have a high risk of breast and ovarian cancer. So you have your ovaries removed for prevention purposes. Or maybe you've had a cancer and you're getting pelvic radiation or chemotherapy, which causes stress to your ovaries, and then you go into menopause early. Women who go into menopause surgically, where the ovaries are physically removed, those women, their symptoms are very abrupt and can be very, very serious and very intense. So we need to be addressing those women and ensuring that they get help right after their ovaries are removed, in addition to the women in early and premature menopause. For women who are in early or premature menopause, you need to get hormone therapy right at the current time of diagnosis, because these women are a different category than women who go into menopause naturally at the average age. These women are at higher risk of heart disease, dementia, and osteoporosis. And if we don't treat with hormone therapy for prevention, they can have these really terrible outcomes. And I see this in real life. And so for women in premature or early menopause, need to see a menopause expert to get on hormone therapy right away and until the age of 51. Here's something that's really interesting. It was only in the 1900s, so only like 120 years ago, where women were actually beginning to outlive their ovaries. So in the 1900s, women were actually dying at the same time of menopause. So menopause was considered an end-of-life event. However, with women now living into their mid-80s, menopause is a midlife event. We have and deserve to thrive in those 30 years and in that 40% of your life. And so I want women to be aware that menopause is not the end of your life. You are not past your prime. You are going through a normal physiologic change. There's lots of things that we can do to support you, and that you have many more healthy years that you deserve to live gracefully and powerfully. What else is menopause? Menopause is liberating for many reasons. Patients tell me they're done with their periods. There's no more flooding. I'm not running to the bathroom, soaking through my pants, or having to wear black pants anymore. You don't need to spend money on pads and tampons anymore. You don't need to worry about getting pregnant with sexual intimacy. So that's also a relief. Women in their 50s and 60s tell me that they have a renewed confidence. They feel more confident. They feel less worried about people's judgments of who they are. Women whose children have now left the homes, they may have improved intimacy with their partner because they finally have time. And this is really an opportunity for women to make their health a priority, because we as women continue to sacrifice our health and well-being for our children, our husbands, our workplaces, our parents, our home environment. And so what that means is that we always become our lowest priority. And I really want women to understand that this is the opportunity for you to start making yourself and your health a priority. Here's a list of the most common menopausal symptoms, of which there are 30 of them. And what I want women to understand is that we actually have estrogen receptors throughout our bodies, from the tops of our heads to the bottom of our toes. We have estrogen receptors throughout our brain and all the different brain anatomy. We have estrogen receptors in our skin, in our hair, in our breasts, in our uterus, in our ovaries, in our vulva, vagina, urethra, bladder, and our bones. And so when you are experiencing symptoms, it is because there is a change in estrogen levels and the estrogen receptors are no longer getting the appropriate estrogen. So in the brain, women experience hot flushes and night sweats, sleep disturbances, mood changes, anxiety, brain fog. We have reduced skin thickness and elasticity. There may be changes in the wrinkling and hydration of your face. There may also be some hair loss. In terms of cardiometabolic changes, there is an increase in weight gain, diabetes, cholesterol, and blood pressure. Women talk about the Canadian Tire around their mid-abdominal area. There is also the genitourinary symptoms where you will begin to experience urgency and frequency, more bladder infections, pain with intercourse, dryness, and a decrease in your libido. These are called the genitourinary symptoms, and these symptoms actually progress with time. They don't get better. There's also something now, we have coined the musculoskeletal syndrome of menopause, where women will start to experience joint pains and aches and arthritis and a loss of muscle mass due to a drop in estrogen levels. And if we don't treat this and do something about this, we have a higher risk of falls, frailty, osteoporosis, and loss of bone muscle mass because of aging. So there are so many things that are happening in our bodies simultaneously. And if we have the knowledge about what's going on, we can then also have the appropriate lifestyle changes to be able to counteract what's happening. Menopausal hot flushes is the #1 symptom that women report, 80% of women, and it lasts for 7.5 years. So women should not be suffering from hot flushes because we have evidence for excellent therapies to treat it. 40% of women still flush when they're in their 60s, and 10 to 15% of women are still flushing into their 70s. So this is a long time to be suffering, and hot flushes can affect all parts of your life in terms of your sleep, function at work, doing presentations, wearing your clothes. It has an impact on your mental health, and so it's not something that should be disregarded or not appropriately treated. Women who have hot flushes have more sleep disturbances because they're waking up feeling hot. They may be taking their clothes on and off, blankets on and off. You wake up feeling tired because you've got unrestored sleep. You have more mental fog, just like when you're postpartum, waking up every 2 to 3 hours to feed your child. This is the same thing. And in fact, hot flushes are a biomarker of heart disease. So there was an excellent study that was looked at where they looked at the thickness of the carotid arteries in our neck. For women who had the highest number and most intense hot flushes, they had the most amount of carotid plaque, so cholesterol plaque in their arteries. So it's important for women to realize that not only are these symptoms very bothersome, it actually can be a marker of heart disease. So we need to treat this, and we need to treat this appropriately. What about menopause and work? So the Menopause Foundation of Canada actually came out with a landmark report in 2023 that really looked at the impact of menopause and work. Women do not bring up their menopausal symptoms at work because they are embarrassed, they are shamed, and they think nobody will understand. Women end up leaving work. 1 in 10 women will actually leave the workforce because of unmanaged symptoms of menopause. 1 in 2 women feel completely alone in the menopause transition. And in terms of an economic burden, for women who choose to work shorter hours, leave work for absences, or actually, end up going on disability, when it comes to the economic burden, there's actually a $3.5 billion annual income lost due to unmanaged symptoms of menopause. Women between 45 and 55 are at the prime of their lives in terms of their careers, and this is also the same age where women are going through menopause. So we need to support women in staying in the workplace because they are so vital to the workforce. And if we don't address this, it has a huge economic burden to the healthcare system and to the finances of our country. So as I mentioned, 1 in 2 women feel unprepared for menopause. 4 in 10 women feel alone. They don't know where to go for help. And even though we as healthcare providers are still considered your most trusted resource, a majority of women, so only a quarter of women said that their family doctor actually proactively discussed menopause with them. And of the women who did talk about menopause with their healthcare provider, 72% found that that advice was actually not helpful, and 4 in 10 women felt that their symptoms continued to be undertreated. And now you understand why. It's because we as healthcare providers have had zero education for 20 years. Unless we have chosen to seek out that information, your doctor will not be able to help you unless they attend the training sessions that we now offer through the Canadian Menopause Society. Now, there is a lot of misinformation. So there's a lot of discussion now about menopause. We are having a menopause movement globally, which is incredible. But what that also means for women is that they are becoming prey to a lot of misinformation where industries and service providers may be working on the vulnerabilities of women because they know that women are not getting the help from their healthcare provider. So they are trying to sell products and services to women at a large, high cost for things that might not have evidence behind them or may not be safe. So my job today is really to ensure that you walk away with information that is based on scientific evidence and that you are getting the resources that you need in order to make appropriate healthcare choices for yourself. So here are some websites I'd like to share with you: the Canadian menopause-society.org website and our Instagram account, the Menopause Foundation of Canada and their Instagram account, the mq6.ca website, which has a website for healthcare providers as well as patients. It has an algorithm and a tool to be able to determine if you are a candidate for hormone therapy and what forms of hormone therapy are safe and approved by Health Canada. And if you're looking to listen to something in your car, this is my favorite podcast, Aging Powerfully with Melissa Grello. This is a podcast that began in January 2024, where she interviews the top menopause experts in the country. Everything from hot flushes to hormone therapy, weight gain, brain fog, mental health, sleep, sex, hair loss, nutrition, exercise. It's all in there. And every single one of the healthcare providers that she has interviewed are providers who are providing evidence-based care. These are all about an hour-long podcast episodes, and I would encourage you to take your time to listen to each one of them because they're full of menopause pearls. The other thing you want to be aware of is the Menopause Society and the International Menopause Society. So when a woman is trying to determine if the advice that she's getting from a provider is actually based on evidence and not misinformation, not trying to sell you something, not trying to make money off of you, here are the recommendations. So the North American Menopause Society 2022 Hormone Therapy Position Statement, it's free. You can access it as a layperson. Just type that in and you'll find it. The 2023 Practitioner's Toolkit for Managing Menopause from the International Menopause Society, also free and accessible. They also have Instagram pages and they have websites, specifically videos for women. And these societies are led by international researchers and scientists who have dedicated their lives to helping women through menopause. Many of them are not found on Instagram. They are not influencers. They are working hard behind the scenes. They don't get the credit that they deserve, but these are the researchers and scientists who are really ensuring that the information that women are getting are based on true evidence and true clinical trials. So what do you do as a woman? How do you start figuring out what to do? So the first thing is you need to start tracking your symptoms. And why I say that is because there is no blood test to determine where you are truly in the menopause transition. As I mentioned, we use your period. And even if we did a hormone level, the reality is that when we do hormone levels for women who are still cycling, irregularly or not, the reality is that your hormone levels change from day to day. So if somebody tells you, let's do a hormone level test to see are your hormones in balance or out of balance, or where are you at? This is really not based on any science or evidence. This is, again, selling you something or charging you for a test that actually has no bearing. So just like mental health doesn't have a blood test to determine you have depression or anxiety, menopause is the same thing. We don't have a blood test to determine where you are at in the menopause transition, except if you are not having a period under the age of 45 and you stop bleeding. And we need to figure out, are you not bleeding because you're pregnant? Are you not bleeding because you're pregnant? Are you not bleeding because you have a prolactin secreting tumor in the brain? And that's where a hormone level test would be useful. Otherwise, for the average woman, doing blood tests are not necessary, nor do they provide us any information about how to treat you. So at my clinic, Milestone Menopause Center, I do have a algorithm here, which I think it's trying to, what happened here? I am now stuck. It's saying my page is not, oh, there we go. It's doing something. Okay, I'm gonna stop sharing for a second, okay, Jessica? Sorry. I don't know what happened here.
Yeah, it might just be loading. Sometimes it's or maybe it's so you can take this question. Is there anything like that in Vancouver? Like, do you know? Because you're meeting everybody now, being the lady that everybody wants to talk to about menopause for clinics in Vancouver. I know there's a couple of different, like the Cheerful Pelvis is in Vancouver.
Okay.
They're
You know what? The Edmonton area is not got a lot of strong menopause primary care practices. Unfortunately, Dr. Kelsey Mills is one of my colleagues, and she practices in Victoria. So she's got a clinic there. Let me just try to share my slides here again.
Yeah, sometimes I've had luck, like when I call
You
a
see,
clinic and I ask if they know anybody else, and then they'll know of someone who is in another, you know what I mean? Like when you're talking about Vancouver versus Victoria,
yeah.
you might start with the one in Victoria and then end up finding something that's closer to you.
Dr. Kirsten Gustafson is an OBGYN in Vancouver, and I'm actually going to be in Vancouver on Monday, and I will find out from my team there if there are any clinics, but I don't actually know. From our Menopause Society, we only have Dr. Kelsey Mills, and she is based in Victoria. So I don't know why it keeps freezing here on me. I have no idea. I'm really sorry.
It's technology. It's a miracle. But people, I think Erica is in Quebec and Vancouver, and I'm in Calgary. Like, yeah, it's a miracle we're all together. So
Do you still see my slides, or you just, what do you see right now?
no, the slides are gone. Did it
Okay.
load up?
It's trying to, but okay, let me just skip to this slide. So anyways, that menopause tracker seems to not be working, so I'll just skip that slide and share this one instead. Present. Forgive me, don't want to waste time. Can you see that?
No, it didn't pop up this time.
No? Okay, hold on.
No.
Share. Oh, there we go.
There you are.
Okay.
Okay.
So I showed you a menopause tracker, but it's not working, so I'm not going to go back. But it is available on my website, Milestone. But you can find any other, you can just Google menopause symptom tracker. There is actually also one on the Menopause Society of Canada website. And so I mentioned to you about the MQ6.ca. And so this is a quick 6 question that both you as a patient, as well as what a healthcare provider should be asking to get a real sense of what are the most common menopausal symptoms that you are struggling with. So that's why it's called the MQ6. You can actually get a downloadable PDF from the MQ6.ca website, print it off, answer your questions, and take it to your doctor. If your doctor doesn't know what to do, at least they know what questions they need to be asking, and at least they know what information to be providing to a specialist for a referral. So are there changes in your periods? Meaning, are your periods heavier? Are they more infrequent? You need to write down how many pads and tampons you're using, how frequently you're changing them, because we need to understand, is your bleeding abnormal? If you're skipping periods, you need to also mention that. What we're looking for is for you to calculate from the first day of your one period to the first day of your next period. That is what is considered a cycle, not from the end of the period, but from beginning to beginning. Are you having any hot flushes? We need to know, are you having them during the day? Are you having them during the night? How are they impacting you? Is it affecting your ability to go to work? Are you waking up in the middle of the night? Are you sweating? Do you need to stop what you're doing? So those are the questions we ask. Are you having any dryness, pain, or sexual concerns? So these are the genitourinary symptoms. Is there pain with insertion? Is there pain with penetration? Are you experiencing dryness? Some people tell me it feels like razor blades down there or sandpaper. Is this getting worse? Are you trying a lubricant? Have you tried a moisturizer? Are you having any bladder issues? So leaking, both with coughing, sneezing, laughing, or urgency where you need to run to the bathroom and you may not get there on time. Are you having any bladder infections? What is your sleep like? Do you snore? What time do you go to sleep? What time do you wake up? How many awakenings are you having? Are you waking up and not able to fall asleep? What are the other distractions in your sleep hygiene? And that is really important for us to know. Maybe you have sleep apnea because women are at higher risk of developing sleep apnea during the menopause transition, and also many doctors may miss that. So that's a huge thing as well. And then with respect to your mood, we have a questionnaire called the PHQ-9 or the GAD-7 that we administer. What we're looking for is to determine if you are having any depressive symptoms. And we know that for women who have a history of depression or anxiety, trauma as a child, PTSD, or postpartum depression or anxiety have a higher risk of developing mood changes in menopause and during the menopause transition. So these are the most important questions to be asking. So once you've figured out your symptoms, you've answered those questions, next you're going to want to do is book an appointment with your doctor. And in that appointment, they're going to review your symptoms. Their job is to assess any of your health risks, and then they're going to talk about treatment options and also discuss preventative health care for you. So what are the tests that need to be done? This is what I ask of all of my patients when I see them for a first-time menopause consultation. And you'll see here, there is no hormone level on here because, as I mentioned, it's not useful. I check these tests to ensure that if you are having any symptoms, have I ruled out other causes for your symptoms? Can we truly attribute everything to menopause, or is there something else going on? I also order these tests to see that if I were to put you on hormone therapy, do you have underlying risk factors that would make you a not candidate or a higher risk candidate? So thyroid function to assess, maybe women who have night sweats or are gaining weight could have thyroid dysfunction. I check iron for iron deficiency because if you're bleeding heavily, that could be the cause of your fatigue and no energy. I check cholesterol, diabetes, and liver function tests. If you're over the age of 50, we start doing colon cancer screening. So I do a FIT test, which is a stool sample. A woman should have a PAP every 3 years. A woman age 40, not age 50, age 40 and above should have a mammogram. And I'll tell you why in a few minutes. If you're over 50 and have risk factors for osteoporosis, then you need to be considering a bone density. If you don't have any risk factors, you can wait until you're 70. And then if you have issues with sleeping, then you may need to be referred for a sleep study to rule out sleep apnea. And as I mentioned in regards to hormone levels, you can see here in that dark blue squiggly line that during perimenopause, your hormonal levels are constantly fluctuating. And so ordering a level for blood tests is of absolute no value because it can change from day to day. So if someone is telling you, I need to check your hormones and then prescribe you based on a higher low estrogen level, that is completely incorrect, not based on any evidence or science. And as I mentioned, the tests are the FSH level, which is follicular stimulating hormone from the pituitary gland in your brain, and the estradiol level, which is the measure of the estrogen production from the ovaries. And the only time those values are necessary is if you are under the age of 45 and not had a period for over 3 months. Otherwise, not required. What am I looking for? So when I'm meeting my patients, these are the things I'm looking for. Do you have risk factors for heart disease? Because if you do, that's also going to affect my recommendations for using treatment and also what that means for your long-term health. So I screen for high blood pressure, I check your BMI, I check your cholesterol, your diabetes, if you're a smoker, and you can actually calculate your own heart health risk in terms of developing a stroke or heart attack over the next 10 years on that website that I've provided there. If you are between 0 and 10%, you're low risk, 10 to 20 is moderate risk, and higher than 20 is high risk. And based on that result, I will also advise a patient if she should take a medication to help bring down her cholesterol, because high cholesterol is a risk factor for heart disease. I also look at pregnancy risk factors because a lot of people don't think about this at all. If you had diabetes in pregnancy or high blood pressure in pregnancy, a baby that was born before 37 weeks, or a baby with low birth weight, these are actually risk factors for heart disease. And so when I'm talking to a woman, I ask about her pregnancy and if she had any of these things happen to her. A woman who has polycystic ovarian syndrome also has risk factors for heart disease, So again, these are other questions that I ask that a general practitioner may miss. So if you know this, you can tell them this information. So why do we need to know about breast cancer risk and why do we need to do mammograms? Because your mammogram and your breast density is one of the things that I will look for as I'm deciding what form of hormone therapy you should be considering, because we know hormone therapy does increase breast cancer risk by a small amount, but having dense breasts, which you can only determine on a mammogram, will actually increase your risk of breast cancer even more than hormone therapy. And so what I'm showing you here is that there's 4 different types of breast density. No matter what your size of breast is, there's no way to determine your breast density except on a mammogram. So you can see here A, B, C, or D. So on the left, you can see the breast tissue looks more black, and on the right, the breast tissue looks more white. So the more white there is, the more dense your breasts are. And the problem with dense breasts, and I will tell you, I'm Volpara D myself, so I've got the most dense breasts. The most dense breasts are the ones we worry about because a malignancy on breast cancer imaging or mammographic imaging also shows up as white. So if you have white on white, you're going to miss a breast cancer. The other thing is having dense breasts, that in and of themselves has a higher risk of becoming breast cancer. And you can see the relative risk here in that blue lines actually increases that risk. So when patients tell me they're scared of having a mammogram or they want to wait until they're 50, I tell them any woman from 40 and above should have a mammogram because we need to understand what your breast cancer risk is and what is your breast density, because there are hormone therapies that can actually decrease breast density and there are hormone therapies that make it worse. So we need to know this. Another really good diagram here is putting breast cancer risk into perspective. So the most highest risk of developing breast cancer is the BRCA gene, and the relative risk is 200. What's the second highest risk? It's not a family history of breast cancer, and it's not hormone therapy. It's having dense breasts on mammography. So when women tell me they're worried about a family history of breast cancer, I fully understand that, but having dense breasts has an even higher risk of developing breast cancer. If you have questions about this and want more information, densebreastcanada.ca has tons of information. It's a wonderful website. Being on hormone therapy really only increases your risk by 1.3 relative risk, and that is not too far off by drinking 2 drinks of alcohol per day or having a BMI of 35. Also increases your risk of breast cancer the same amount as being on hormone therapy. So now that we have done symptom tracking, we've now done risk factor assessment, we've looked at your heart disease risk, we've looked at your breast cancer risk, what's next? Well, now it's my job. I come in, or the menopause specialist comes in to individualize the treatment plan based on shared decision-making between the patient and myself, and ensuring that all the therapies that we are prescribing to you are based on evidence-based products, not things which are not approved by Health Canada. So hormone therapy is actually considered the most effective treatment for hot flushes and night sweats from the Canadian Menopause Society, the Menopause Society, and the International Menopause Society. And as I mentioned, there's a window of opportunity that is for women under the age of 60 and within 10 years of their final menstrual period. What are the considerations that I think about when I'm individualizing my therapeutic plan for a patient? Number 1, does she have contraindications? Number 2, how old are you? We've talked about the window of opportunity. Number 3, are you perimenopausal and still getting periods, or have your periods stopped? Because your regimen will change depending on where you're at. Do you still need contraception? 40-year-old women are still able to get pregnant. And so we want to ensure that if you're using hormone therapy, that doesn't provide contraceptive benefits. So maybe a birth control pill may be something that you may require. What's your heart health? What's your breast health? We've talked about that. What is the regimen that you feel confident that you will be able to comply with? What are your preferences? Can you afford the medication? And do you have insurance coverage? These are the questions I'm asking myself and of the patient.
So we just have a little question in the
Sure,
chat.
sure.
Estradiol and micronized progesterone do not increase the incidence of breast cancer. This is something that they thought, and it was progestin that slightly increased the incidence. Is
So
that
progestins,
yeah,
so let me just clarify the terminology. So there's a overarching term, which is called progestogens. It's all the forms of progesterones out there. Then there's progestins, which are synthetic progestogens. And then there's micronized progesterone, which is bioidentical progesterone. When we look at the breast cancer risk, the progestins do confer a slightly higher risk of breast cancer. Micronized progesterone in general only increases risk after 5 years of use, but it's not negligible. So women need to understand that hormone therapy with some form of progestogen does increase breast cancer risk, but higher more so with the progestins, which we don't use very often these days. And micronized progesterone is the better option when it comes to breast cancer risk, but it's not negligible.
And the estradiol, has it been linked to the incidence of breast
So
cancer?
estradiol and estrogens actually, so in that Women's Health Initiative, if we go back to the 1990s Women's Health Initiative, they had an arm of women who were on estrogen alone because those women had had a hysterectomy. And in fact, women who take estrogen alone have a decreased risk of breast cancer. It's the women on estrogen and progesterone together that have an increased risk of breast cancer. So estrogen alone decreases risk of breast cancer. And if you want me to show you the data later on, I'm happy to. I'm happy to show you that slide. I just didn't include it in here, but it's estrogen alone that does not increase breast cancer risk. It's the combination of estrogen and progesterone.
Okay. So Erica, you can chime in again if you have more questions, and I'll interrupt, but let's keep going.
Okay, so in terms of contraindications, here are the contraindications. There's not very many of them. So a history of breast cancer, coronary heart disease would be heart attack or stroke, any estrogen dependent cancer. So we've got endometrial and ovarian cancer. I would say that we do have evidence that women who've had early stage endometrial or ovarian cancer can use hormone therapy, and I do currently have patients on it. So it really just depends on the situation. A history of blood clot, we do have good evidence now that women who have had a provoked blood clot versus spontaneous can actually use transdermal estrogen. So it's sort of a relative contraindication. A history of stroke, a history of a blood clotting disorder, active liver disease, or any form of suspected pregnancy. That is it, which means smokers can use hormone therapy, migraine women with migraines can use hormone therapy. Women with diabetes, high blood pressure, high cholesterol can use hormone therapy, but we have separate ones for them. So here are the other considerations, which I've already sort of mentioned. A hysterectomy,
Interrupt you again and warn you because we're at 15 minutes, so I'm not sure if if you wanted to see if there's more questions or
I'm
you know
on slide 34 or 42, and really the rest of the slides are just demonstrating what the various forms of estrogens are and progesterones, and these are all available on the website, so I can definitely stop and start taking questions. I think I've addressed most of these already. So let's take a break from the slides, and I'm happy to answer questions. I'll just stop sharing here. Okay.
Yeah, so you guys can chat. You can put questions into the chat if you have another one. But I think the real message that I'm getting, and that I talk about a lot in the group, is it's really an individual situation. It's very hard to say, yes, you can have this and yes, you can have that, because well, you don't really know someone's personal history or exactly what their weight is or what's happened in their family or what genes they have or any of those kind of things. So each individual person needs to have that conversation with their doctor and make sure that what they're getting is appropriate for the condition that they're in, and that it won't make how they're feeling any worse, or the condition, like there are certain things that would be contraindicated. But even just from what you're saying, it sounds like even cancer, you can't just say, no hormone therapy, because I've heard that a lot. No hormone therapy if you've ever had cancer, if you have cancer in your history, in your family, and migraines for sure. I hear that all the time. No estrogen.
So yeah, so diabetic, so there's a difference between oral estrogen and transdermal estrogen. So for the average risk patient who doesn't have any contraindications, you can use an oral estrogen completely fine, and I use them for many patients, but there are a subset of patients who may have comorbidities is what we call them, where we may want to particularly use a transdermal estrogen. So for women who are diabetics, elevated BMI, high cholesterol, blood pressure, smoking, liver disease, you would want to use a transdermal estrogen. Also migraine patients. And then the ones that are actually protective to the breast, those two products, one is called Duaviv and one is called Tibolone. People don't know about these medications or Health Canada approved hormone therapies that actually decrease breast proliferation. So if a woman comes to me who wants hormone therapy, is worried about the breast cancer risk of hormone therapy, if I put her on Duaviv, which actually decreases breast cancer risk, not only am I treating her menopausal symptoms, protecting her heart and her bone, I'm also protecting her breasts. But because most healthcare providers have a very small toolbox of options, they may not know to offer this. They may not know to check the breast density. So my job is really here to help empower women to know what to be asking for, because then that will help their doctor dig and ask for more information. And if they don't know what to do, tell your doctor to go to the mq6.ca website. There's a very easy algorithm. It'll tell you what to do. And it'll tell you what the approved products are in Canada and the appropriate dosages as well.
Yeah, that's an excellent tool because that's one of the things I've had a couple of times because I do offer to talk to people about what's going on for them when they get really, honestly, there's so much fear mongering, I think.
Yes.
Um, maybe preying on the fear of women or just, you see the algorithm and then it keeps showing you these things. Like I always find cat videos and dog videos because that's my thing. So it'll
Yeah.
always just feed me that because that's what I want to see. And I had one person asked me specifically about the mammogram because she really was afraid of the radiation of the mammogram and she really didn't want to go get the mammogram. But she had a doctor who was willing to prescribe the hormone therapy, insisting that first we're going to do the mammogram before we prescribe. And she was asking me why. And I said, well, let's just say there is something going on with your breast, and you don't know, then now maybe they've made it worse because they don't know they've given you something that's inappropriate. And she said, oh, no, I would know. And I was like, honey, I have had 2 lumps removed. And the second one, I couldn't feel. It was found on a routine mammogram and then confirmed through an ultrasound and then through a needle biopsy that they couldn't tell exactly what it was. So I opted to have it removed because removed means it can't possibly harm me. And I have a scar. I would rather have a scar than potentially have illness. So the doctor, even though it seems, unnecessary to you, they know this bigger picture of what could happen to you if you don't go through the steps. So they're actually doing you a favor by asking you to go and get the mammogram. And as far as the radiation goes, I think it's pretty comparable to getting your dental x-rays. Like I don't, I personally have no problem with it.
I think it's even less than the flight to Vancouver.
Yeah, which is an hour and a half or something, right?
Right.
Like,
Actually, I have a slide. If you give, again, I have slides for everything because I
yeah.
want to show data. It's in my inbox somewhere, but I have data specifically on the amount of radiation for a mammogram, and it's nothing to be worried about. I didn't. I mean, myself, I always thought I was going to wait till I was 50, and when I started to learn about the breast density information and how that affects a woman's breast health, risk for breast cancer, and as part of the risk assessment to start hormone therapy, I didn't hesitate. And I now tell all of my patients, and I literally saw a woman yesterday who's 52, who's never had a mammogram. The last one she had was back in Europe, and she just said that they told me one day and they squeezed her breast and didn't give her any anticipatory guidance. And so she's very deathly afraid. And after I explained to her what the role of it was, why I wanted it, what the benefits were to her, I was able to convince her to get it done. So I think it's really important that as healthcare providers, we listen and validate what the patient is saying, but in addition, help counsel them about why we're recommending something so that they can understand. And with that, they will, it's informed decision making so that they now have comfort in knowing what it is and knowing what the purpose of it is as well.
And then we have another little comment about why, when I asked 2 months before my 40th birthday, they refused, even after I told them about the risk in the genes. And this was at a mammogram site. Why would someone be refused a mammogram? And I think provincially the rules are a little bit different as far as
Provincial
what,
rules are different, and
yeah.
The Canadian Preventative Task Force on Breast Cancer Screening is outdated. They're still not recommending before 50. So now we need to advocate for ourselves. In Toronto, women can now self-refer at the age of 40. And in Alberta, it's 45. You don't even need a doctor's requisition. I don't know what it is across the provinces, but if you go to densebreastcanada.ca, they'll be able to tell you.
Mhm.
what the different provincial guidelines are.
Yeah, well, my doctor, I had my first breast lump when I was 37, and I found it, I could feel it. And so after that, I was identified as having dense breast tissue. And that lump again, same thing. They couldn't tell what it was, so I opted to have it removed. And it was nothing. It was fine.
Mhm.
Which I was so grateful for. And if I hadn't had the really good doctors checking up on me, they might not have caught that second lump. And again, when they removed it, it turned out to be fine. But, from my understanding, things can change pretty quickly, and you don't really want something in your body that could potentially turn into something that could be, dangerous and sinister. And why not get that dealt with? And when I was talking to my doctor about it, she said they did a study, and I think it was in Sweden, one of the smaller countries where the population is really dense, and they moved the dates earlier, so say from 50 to 45, I think it was, and they caught so much more breast cancer. Like, it was ridiculous. She said it as soon as I saw that, I was like, "Every woman over 40 is
Mhm.
going to get their mammogram for me," and she's caught a lot of illness by doing that, and I just really trust her judgment, and, I'm very lucky, but, she helped me have my 2nd child, so we have a special relationship, and
Um,
she's retiring soon, so I'm gonna be looking for a new family doctor, which is a little bit terrifying right now. Um, but, I always say that to people when they're like, "How do I talk to my doctor?" I don't know if you have any wisdom about how you can talk to your doctor if you're feeling like you've gotten into we don't do that for you, and we're not gonna do that, and you're in, like, a power struggle. How do you come back into a place of, like, "We have to work together here for my health and well-being?"
I think if you refer to the Canadian Menopause Society, because you want to ensure that if you're going to be talking about menopause with your doctor who feels uncomfortable, that you are sourcing a credible website or a credible company or an organization. Excuse me. And if you provide that recommendation, then your family doctor can choose to take the onus on themselves to go do that homework for themselves. If they feel uncomfortable, then at that point, obviously, you'd be requesting a referral. And what you're looking for is you can tell them that I would like a referral to a menopause specialist if you can find one in your area. If you're not sure, you can say, I would like to see somebody that has a Menopause Society certified practitioner designation, the MSCP. You can actually find all the MSCP providers in Canada on the Menopause Society website. And remember, not all MSC providers are providing evidence-based care either. So again, misinformation and women getting misinformed is still a huge thing. But what you want to remember is if they have that designation, at least they've passed that exam. And secondly, if they are prescribing you hormones, you want to ensure it's a Health Canada approved product, not compounded. And third, if they're asking you to pay for their service, and charge you for lab work, that might be another red flag.
Mhm. Yeah, when I don't know if I ever told you this, but I have endometriosis, and I was trying to get into a gynecologist. My referral was lost twice, and eventually I drive to Canmore to see Chelsea Topping at the Canmore obstetrician clinic, and she does her own surgeries too, so she did a surgery for me. But she said that she ends up seeing a lot of people who will do the drive to see her because they can't find anybody because Calgary is just that busy as far as trying to get in to see a gynecologist.
It's currently at least, I would say, 12 to 18 months. And my wait time right now is 15 months as well. Now, also my consults are 45 minutes. I cannot do all of that in 10, 15, or 30 minutes. Not only is it assessing symptoms, it's doing the risk assessment, it's doing the education, the counseling, the answering questions, and writing a prescription. So it
Mhm.
does take some time.
We have another little question here. I was under the impression estrogen should be prescribed with progesterone. Just read the Estrogen Matters. What do you think of the Estrogen Matters book? You've probably heard of that one, hey? Like Estrogen Matters. They wrote a whole book
I've
on.
heard of it. I have not read it. You absolutely should be prescribed progesterone with estrogen if you have a uterus. However, if you're using Duaviv or Tibolone, or if you have an IUD, those products already contain a form of progestin or have some molecule in there that acts like a progestin or progesterone. So you do not need to take a separate form. In addition, if you are using vaginal estrogen, you do not need progesterone. So this is only for systemic estrogen therapy.
Right. Yeah, I haven't read Estrogen Matters either, but it's on my list of ones to check out because keep hearing. I actually found out about it from a podcast where it was like just so enthralling, where they were really like, we've just done a disservice to women where they have been, underserved. When you're talking about the last 20 years, I'm doing the math in my head and thinking, oh my goodness, so that's a lot of ladies that didn't get any proper care in that window of opportunity.
And
And
that's my mom included.
yeah, that could be scary because the osteoporosis and the dementia. My dad had dementia and my mom had osteoporosis. So I'm 54. I'm going to see my doctor on Monday and I'm going to ask about the bone density. I'm sure that mine is probably pretty good because I work out, I do weight training, and I'm a yoga therapist and I walk my dog like she's spoiled. She gets walked like 3 or 4 times a day. But I still want to know. I want to know for sure. And I also was thinking it was maybe a good idea to have a baseline of where I'm at right now because I'm not through perimenopause.
Right.
Then we would know like how things are changing when they change. And I really encourage everybody to like ask for the testing and go through the testing that you can, to get a good idea of what's going on, and don't guess. And then Erica's saying there's apparently a study showing that women taking estrogen alone, the ones with the hysterectomy, are more at risk of ovarian cancer without the progesterone.
So, Erica, if you could share that study, that would be great so that I can see what the source is. I wouldn't be able to comment on it without it, but that is not something that I have heard. And ovarian cancer is one of the lower risk cancers. One of the ways for women to prevent ovarian cancer is by having their uterus, by having their fallopian tubes taken out. So if a woman is actually having a hysterectomy for any other reason today, women are also getting their fallopian tubes removed. Ovaries stay in place, fallopian tubes are removed, and that actually does decrease ovarian cancer risk. So I'm curious to know where you get that, where that data is coming from.
Yeah, and I know that you can definitely share that. Um, she's trying to find it.
No problem.
Yeah. Okay.
I
We're
hope, I
at
hope
the
I was able
hour.
to provide some education for the individuals that are on the line today.
Yeah,
Thank you
and I
for
think we
coming.
covered a lot of really good ground. And if there is anything else that's pressing, what would you have any final thoughts? Or if anybody has any
Um,
questions?
My only final thoughts is just as women, don't underestimate your symptoms. You are worth and deserve more than that, but also be really careful about misinformation and ensure that you are really critically appraising the information that you're provided and ensure that the person that you're getting information from is somebody who has a credible designation. They belong to some sort of a credible organization. They're not trying to sell you something. They're not trying to make a profit off of you, and that they're really there to provide education and give you a toolbox of options that meets your needs versus specifically trying to sell something to you.
Hmm. Yeah, I always tell women like, so you go to someone and you ask for help and they say no. Well, I mean, no in this case isn't good enough.
I agree.
If you're talking about osteoporosis and we're talking about dementia and we're talking about our long-term healthcare, as far as like how well is your family going to function if you really can't stand being away from the bathroom? You can't even go to the grocery store and you can't work at all anymore. Now you're down in income and you're not really able to go even play with your kids. This is just not right to leave people in that kind of situation. So I keep saying, keep asking for help, keep talking to people about it, because it's been my experience that the more you do that, the more you'll find people that are willing to help you and people who know other people who can point you in the right direction to finding the person that's going to be able to help you. Just like for my referral, if I'd been like, oh, well, who cares, whatever, I have endometriosis, I'll just put up with it until it eventually I'll go through menopause. I'm 54 and I'm not there yet. So who knows, maybe I'll be one of those, outliers in my late 50s. But it's not good enough. So I just kept talking about it. I just kept talking about the symptoms and that I wanted more help. And then this miracle person, Chelsea Topping in Canmore, for anybody in Alberta, she is like she did the surgery herself. And before we did the surgery, I reminded her I'm very conservative in general. I'm really careful about what I put into my body and how I treat myself. And I took a long time humming and hawing about the surgery because I don't want to do anything. I have trouble with violence as a yoga therapist. It is a violent act to cut into the human body. However, if there's stuff in there that's making you have pain, and for me, it was becoming like a daily pain. I was just always in pain. Now, my quality of life has just gone down the tubes. It's far better to go and do the surgery. And I said, just to remind you, I'm the very, very conservative. Please take out anything that needs to go.
Did she
But
take your fallopian tubes out?
nope, she said, you know what? Everything was healthy. You just had cysts on top of the ovaries that I was able to scrape off, but they're not of a concern like
No,
what
no,
I'm
no,
worried
the
about.
fallopian tubes, not the ovaries.
Nope, she didn't take anything.
Oh,
She
interesting.
just she just went through and she was like, you were riddled with endometriosis. No wonder you're in pain all the time.
I know Dr. Topping, she's lovely.
Yes, she is lovely, and, it's, she kinda looked at me like, "Why are you reminding me of that?" And it's just because I wanted to make that connection with her, right? Remember who I am, and I had no nerves. I was so calm, and I recuperated very well, and I'm incredibly grateful that that was the right path for me and that it worked, and, now I feel kinda silly for taking so long humming and hawing about it, so I tell that to women. I tell people that story, you know, don't just sit with it until it's really destroying your life.
No, it's not. You deserve more. Each one of you deserve more. We all deserve more.
Okay, so if there's no questions, we'll let Shafina go because probably maybe your husband made dinner.
I haven't even ventured outside to see what the situation is.
Oh, you're welcome, Cree. Thank you for coming. Thank you for
Thank
being
you,
here.
Peri. It was lovely to meet you as well, and Jen and Erica. And I hope I was able to give you some new perspectives today.
Yeah, and thank you so much. You're just delightful, and we've really been looking forward to having this chat. And I know that Cree wants you at her doctor.
Also, I want to say, Jessica, you've put in so much of your heart and time and effort into your Canadian perimenopause support. Is that what it's called?
Yeah,
And
Canadian
I know
Perimenopause
that
Center.
your heart's in the right place and you really want to create a platform for women to share their experiences and learn from each other. And I just want to humbly thank you for that because, you're probably doing this out of your own interest, passion, free time. And so I just want to take a moment to honor you, to thank you for all that and all the work that you're doing to help women. Because I think isn't enough of that happening. So thank you.
Oh yeah, it's I really appreciate any of the kudos. I had some pretty negative experiences this week. Some just anytime I think you and I said like when you put yourself out there, sometimes some negative stuff will come back and it's almost like a challenge. Like, do you actually mean it? Is this actually important to you? And when I myself had perfect blood tests and I was messed up, I sat in the car crying like I felt like I was crazy. And I said to myself, there's probably 1,000 other women right now today doing that, feeling like they're completely nuts and just been told by the doctor that they're fine. And where do they turn to? Like, who's going to be there to listen to that? I mean, there are like distress lines and people you can call and such, but there isn't really anything about the perimenopause. I
Mm.
wanted to talk about the weird stuff, because things can happen and it's not like first you have this and then you have this and then you have it's like mine was just all over the place and it just grew and grew and there's obviously such a need and I run 4 volunteers. I have 4 other ladies
Wow.
that love to help and keep it a really as much as possible a very safe space to talk but when I get in there, if I hear people being unkind or, saying stuff like, oh, I one time had someone say estrogen causes breast cancer. And they had quoted canadiancancer.ca website.
And that website, I have emailed them 2 times to tell them that their website is wrong, and no one has ever gotten back to me. I even wrote a letter on behalf of the Canadian Menopause Society. They are completely making women unnecessarily worry, and it's a credible website. And so I see that, and it makes me really upset.
I was like, no, man, like if you actually read through the whole thing, it says estrogen and progesterone is safe, but you have to read through the whole thing to get the information. Don't just pull out the one part, you're spreading fear and it's
Mhm.
not kind. And kindness is like
Number one.
for one, let's stay kind. So if someone's doing something weird that you don't think is right for you, then you don't do it. But if they want to do it, it's fine. It's just, there's certain things that I think are not exactly legal in Canada, so I don't allow those particular posts. But if people want to go and do it, I'm not going to tell them not to, but I'm going to tell them that it's not exactly legal. So,
Right,
you know,
absolutely.
yeah. So maybe make sure that you're doing things that are, be supervised, someone's looking out for you, someone's checking in on you, making sure that you're okay. Don't make weird decisions all on your own and decide that you don't need help, because it's pretty murky. And that's all I got to say about that. So yeah, yeah, no one's looking out for you, Cree, but you got to just keep talking to
Cree,
people.
where does Cree live? In
Vancouver, I think, right?
Vancouver. Cree, you should ask for Dr. Kirsten Gustafson. She is lovely. And if you can get into Dr. Kelsey Mills, it's a bit of a wait in Victoria. She's a doll. Both OBGYNs who have such a good heart and wonderful people. Please write those names down, Cree.
Yeah, and it should be also available in the when I send out the links for all of the
Okay.
replay stuff, the transcript will be there. So it should be the chat
Thank
transcript
you.
there as
Thank
well.
you so much for today.
Yes, talk to your doctor on Monday. Everybody talk to your doctor.
Yes, I agree.
Okay, thank
Advocate for
you so
yourself.
much. Have a
Okay.
wonderful weekend.
Okay, take care. All the best to you.
Bye.
Bye. Bye. Bye.